7, 5, 4, 3, 2, 1. We are live.
So, good evening, all. Today, it's a great pleasure to be here in this evening program. It's a online masterclass on Spondylo Arthropathy, and for that we have galaxy of speakers across the country. And on behalf of organizing team, I welcome you all. Along with me, I am the course in charge of this program, and along with me, we have two moderators. One, Dr. Aarti Diwan from she is faculty from the Guru Ramdas Institute of Medical Sciences, Amritsar, and we have another eminent faculty from IPGMER, Calcutta, Dr. Arnab. So they will moderate the session, and we have the speakers, and along with not only the speakers, but we have eminent faculties. Apart from the speaker, they can also guide us, they can also suggest. So without wasting time, I think let us start the session. And the first speaker for this session is Professor Manish Khanna from Lucknow. Sir needs no introduction. He is an eminent speaker, and he has a lot of work on the orthorheumatology. He is, you can say, the one of the key person as far as orthorheumatology is concerned. So I request Professor Manish Khanna to start his deliberation. His talk is on
Dr. Keskar,
We'll request our president.
Our president of IOA, sir,
right.
You will, sir, have some.
Oh, sorry.
Inaugural
Sorry. So I beg pardon. So I request our president, sir, Professor Ramesh Sen, sir. I invite him for welcome speech, sir.
Thank you, Dr. Keshkar. So, good evening, friends. Definitely, this is a program from our spine subcommittee, and definitely we wish that we should be talking about a problem which affects a sizable percentage of our population, especially when it is linked not with the spine only, when it's associated with a lot many symptoms out of spine also. And when we have got this kind of inflammatory pathologies in the spine, the kind of a symptomatology the patient present are likely to be numerous. And obviously, detailed discussions, and if you see the topics today, we have got a lot many things to be there in the program, and I feel all of them are very important. And as we have very eminent faculty also, which has been there to teach us, to talk about all spinal issues, I feel this is likely to be a very useful program. So all my best wishes for this program also, and I definitely think that the participants will be benefited a lot, and we definitely hope they will have a lot of interaction also with the faculty. All my best wishes. Thank you.
Thank you, sir. Thank you for the kind words. And now I request the
Dr.
chair.
Keskar, I'm tempted to say a few words. Please permit me to do that.
Yes, sir.
Okay. So I would like to say that this is an extension program almost to a program started by Indian Orthopedic Association in 2019. And IOA, under the leadership of then President Dr. Rajesh Malhotra, thought that spondyloarthritis patients, more in number as compared to rheumatoid arthritis or even comparable numbers, report to orthopedic OPDs. And so he said, let us physically, that was pre-corona era. So he had thought of physically training all the basic orthopedic surgeons. And so a team of 11 consultants who were called master trainers were trained systematically, and slide decks were prepared. I'm very happy that many of them are present here. Dr. Dhansekhar Raza is there, Dr. Ravi Gupta is there, Dr. from Madurai, Dr. Raja Mani is there, and Dr. Amarnath is there, and Dr. Manish and all have joined later. So with these words, train the master trainers. I wanted to inform everybody. Now back to Dr. Keskar.
So thank you, sir, for nice information. And before we move on, let me invite Dr. Naresh Babu, the chairman of the Spine Society, Spine Subcommittee of IOA, to say a few words before we start the academic program.
Thank you very much, sir. At the outset, I'm very thankful to Rheumatology Society of India for taking initiative and chipping the spine inside the program. And heartfully thanks to Professor Ramesh Sen sir for joining in his busy schedule to wish us to start our series of webinars on this particular topic. And I thank other members of our spine committee, especially Dr. Partha, who took a lot of pains to integrate both the societies to come out with a very good program. I hope the deliberations will be very useful to all the participants, and I wish the program very success. Thank you very much, sir. Over to you.
Thank you, sir.
So yeah, please allow me to share the screen. Well, good evening, namaskar to everyone. Approaching spine ortho-rheumatology. So definitely, as it was very exciting to have comments from legends here. Orthopedics was a trauma orthopedics decade back with a conservative treatment, moving to the surgical treatment. Now, for the last 2 decades, we are into a lot of those important aspects of orthopedics, joint replacement, arthroscopy, all those things. And spine orthopedics, spine subspecialty, when the orthopedic surgeons are overemphasizing and doing a lot of wonderful work to the spine. Definitely spine means trauma and all those things, but definitely yes, spine ortho-rheumatology is a big issue which is now being focused for the last 2-3 years with the help, with the umbrella of orthopedic rheumatology, because we deal a lot of spine spondyloarthropathies, and even if the spondylolisthesis is there, sometimes it may be having a component of spondyloarthropathies. So it is not only the surgical, but now orthopedic surgeons are emphasizing on the medical needs, because once you are very much comfortable with the medical requirement of the patient, then definitely the results will be far much better, along with the rehabilitation part, which is the most important thing which we miss sometime, but has been emphasized in the western part of the globe. This is very important. So we all know for this topic that arthritis involving the axial spine is Spondylo Arthropathy. Now, why the complete knowledge of spine orthorheumatology concerning to the Spondylo Arthropathy is important? Because definitely, yes, the OPDs are having a lot of patients with the arthritis, and these seronegative arthritis patients, they complain about the spine problem. Now here, if we can click over it and catch over these patients, and not only this, lot of the issues with the degenerative osteoarthritis is not only a thing which is restricted to the knee, sometimes to the hip, it is there in the spine also. The gout have a wonderful presentation, hyperuricemia have a wonderful presentation to the spine. So there are a lot of entities which we miss in OPDs, all while treating the patient surgically. Yes, it is very much true that spondyloarthropathies are the second to the rheumatoid arthritis. That means 1 to 2% in the globe, the billion population in India, are having a rheumatoid. So 0.5%, less than 0.5% is a big chunk of the patient. These patients comes to the OPD with a low backache and we prescribe, okay, low backache, go. No, it's not like that. We need to work out these patients to find out, to extract which are the right patient for the spondyloarthropathy. So 1 to 2% of low backache in OPD may be having SPA, spondyloarthropathy. This 1 to 2 is a big chunk of the patient which needs to be diagnosed properly, treated properly, and definitely whenever the surgical intervention is required. Now, this textbook Orthopedic Rheumatology, which is very well available in the country, is the textbook which we are focusing a lot of the spine problems on this. A lot of the chapters are there with the surgical intervention. What are the surgical intervention which is being required? Now, this is a usual presentation in our OPD. We are seeing a lot of trauma patient. We are dealing with the trauma patient. We are doing interlocking or whatever it may be like. And these patients gradually, when they come to the OPD, when their nail is being in, they're about to walk, then they started having a pain in the spine. Now, this is also a thing which we forego most of the time, that it is maybe a misnomer, a spinal anesthesia problem. But actually, if you take these history, then even in your trauma patient, you'll come across a lot of the patients who are having a lot of episodes with a pain of the joint, which may be inflammatory pain, mechanical pain, need not to discuss here because today we are having a lot of discussion, but definitely a good history taking can pick up these symptoms right from the day of the stitch removal or your follow-up of 4 weeks. And definitely a small history of a morning stiffness, maybe not exactly the bookish picture of more than 30 minutes, a small history of the morning history of stiffness, or waking up pain of the buttock pain, restricted spine mobility. They are the good clue which can pick it up, the inflammatory arthropathy in the spine. So these are the early spine spondyloarthropathic patient, and the beauty of orthopedic surgeon should be to pick it up as a early stage, not to prolong it, because the billion population is increasing and increasing, and the cases are increasing like anything. Similarly, again, if you're doing arthroplasty, and again, we are having all these type of history taking which should be required. For example, as been very well explained and pointed out by our president, that not only a spondyloarthropathy, even a burning sensation of the spine, which we may miss, may be a case of a fibromyalgia. So these are the things which again to be treated by orthopedic surgeons. Not a big deal. Only we have to differentiate it in which direction we want to go. And with lot of in the country diagnostic setups and different investigation, a big profile coming to your OPD in front of you, say having HLA-B27 positive, ANA positive, the patient is saying, okay, we are having this spondyloarthropathy. No, it's not like that. It is a dilemma of the patient. It is the work of the orthopedic surgeon, a spine surgeon, to find it out whether it is to be a case, because HLA-B27 is normally positive in a lot of the population. We have to work it out whether enthesitis is there or not there. We'll have a discussion today on this also, so that we can pick it up. And there are a lot of beautiful modalities, not always required to go for MRI. Just a good ultrasound pickup can help you out to pick an early case of enthesopathy. So in a nutshell, I would like to say that undifferentiated spondyloarthropathy is the most commonest. Please don't try to make it a diagnosis on a letterhead. We can write an undifferentiated spondyloarthropathy and just try to treat it as early as possible, because if you're not going to do it, we are going to land up in the classical case of syndesmophyte and bamboo spine and this and that, and then the surgical intervention would be really very difficult. Multidisciplinary approach has been required by orthopedic surgeon, by physiotherapists. Just we should work on the same parameter as the Western culture be, and just try to focus these patients with all the angles possible. Thank you so much. We want to say that all these latest details are being there in the textbook of orthopedic rheumatology, which anybody can have it from the Amazon also. Thank you so much. Thanks a lot.
Thank you, sir. Thank you for your excellent presentation. It's really an eye-opener lecture as far as spondyloarthropathy is concerned. So as we have decided, we will take questions at the end. So now I invite Professor A.K. Pal. Sir, are you there? Professor Pal is already there. So, sir, are you?
Please
I heard that you are
slide,
traveling,
which is already recorded. Please run my slides, which is already recorded.
Okay.
Because I am traveling.
Okay, so I request Dr.
Yes, sir.
So
I'm sharing the screen.
Professor Pal is actually traveling back to Calcutta from Jalpaiguri. So I request Dr. Partha to run his slide. Dr. Pal, please mute yourself, sir.
Yes.
Okay, just you invite the next speaker. I will. I just there is a technical issue. I will after the end of this speaker. I will make this run on this. Bhaskar sir, please.
Okay. So
Shall I send to Arnav? Shall I send the file to Arnav?
Yes, sir. You can send.
Yes, yes.
okay. So we will run that that slide at the end of the
So I think
end
we
of
can
the.
move to the next lecture. By that time I receive, we can.
So let me invite, without wasting time, let me invite the next speaker. And the next speaker is none other than.
May I request Dr. Pal, please mute your mic. Dr. Dilip, please mute your mic so that it will not be a disturbance for the rest of them. Thank you so much.
Okay, thank you, sir. So now let me invite the next
Next will
speaker.
be Dr. S.S. Amarnath, sir, from Bangalore. Will speak on angst-spawn diagnosis. And I have received Professor Pal's video, so whenever we are okay, we can run that. Amarnath sir, please unmute yourself. And you can start your presentation.
I can start your presentation now. Okay,
Yes.
okay. Thank you. I will start to share the screen just a minute. Okay. Are we all able to see the screen?
Yes, sir. Screen is visible, but your PPT is still coming.
Yeah. Screen is visible. Now I think it will be coming on.
Yes. Yeah, perfect.
Is it on a PPT mode for you all?
Yes, sir. Perfect.
And the voice is clear as well. Great. Thank you, Arnav. At the outset, this is me, what I'm doing, and then thank you for being invited faculty for the IOA Spine Subcommittee and to share a few thoughts. Dr. Manish has made my life very easy, and I've hid a lot of my slides now. So there will be some repetitions probably, but yet the speakers will have a bird's eye view of all the things that we are talking about. End of the day, see, we need to understand very, very clearly, how do I need to diagnose? Is there any criteria that I can put on? And also at the same time, how can we pick it up early so that we can avoid the life-threatening deformities that many of us have seen and face on a, if not daily, on a regular basis in our OT. And many of us have seen the challenges that we go through with that kind of a surgical intervention that we are facing. And we have treatment available where we can prevent a lot of these deformities very early on. And keeping that in mind, let us take the next step. Our professors back in time, I'm sure even now, all the professors are teaching the same thing. Take a good history, and a proper clinical examination gives you 90 to 95% of your diagnosis extremely clear. That's very important. Blood and X-rays obviously are a part of our routine to make sure that we diagnose the right way, differentiate the differential diagnoses that we have, and at the same time give the right kind of treatment, appropriate treatment, as well as in an appropriate time, which is extremely important. Now, let us talk about a few pointers on the history. Manish made a very clear-cut, pointers there, so that's very easy for me. Now, any other risk factor, I take it there, because you and I know that we may have hormonal issues, we may have coexisting comorbid conditions, and also some of the seronegative or a seropositive arthritis or any other autoimmune conditions which can coexist. One autoimmune condition doesn't mean that he or she is end of that. No, they can have multiple of them, at the same time, if not, occurring in a different phase of times, and then all in one person. We have to identify that and make sure that we are. And mind you, nutrition is one of the biggest thing that we need to talk about as well. But anyway, I'm not taking there. In terms of the blood test, what we do, the blood test is extremely important. So I'm talking about a few things here. ANA profile, I don't want you to do ANA profile for every patient walking into your chamber or a consultation room or a hospital. When the ANA is positive, then we can go into the dsDNA and an mRNA, all those factors. So just be careful and request the laboratory, if the ANA is positive, only then to run the ANA profile. Otherwise, it's going to cost the patient a huge amount of money there. And we need to pick up the RA factor and the CCP, if anti-circulating citrulline peptide, which is very important for us to make sure whether the person is in seropositive or a seronegative arthritis. So that is very important for us. So similarly, electrophoresis to make sure that there is no M-band and other things to be there. We need to clearly understand the pain factor. Is it mechanical, inflammatory? This is our responsibility to guide the patient in the right track, because the treatment is very important for us. Many of them come extremely late with all this unfortunately, in that true sense of term, or fortunate, well-informed patient is a better patient, we say, but still we have much bigger, much better or over-informed patient, which they get hyper with little things they see on the press of a button in a phone. So that's the biggest challenge that we face in Bengaluru. I'm sure many of you are also facing that. Now, in Anki spine, what do we see? We see it pretty early. In teens, we can pick it up. That's very important for us. And 80 to 90% of them are having the human leukocyte antigen positive. Very important. It may not be there, but definitely morning stiffness, as Manish was talking about, doesn't have to be 30, but on an average, we talk about it could be 10, 15, it could be many minutes later also. This is the biggest thing. A lot of patients come back and tell us early hours in the morning, post midnight, I'm getting severe pain. It could be not just in the back, not just in the lower back and sacroiliac region, but in the neck as well. Anki spine can start majority of the time, IS, very important, but cervical, we miss many times. We just say, oh, it's simple cervical spondylitis. Absolutely not. I think we need to make sure that we clearly take it up. Enthesiophytes, enthesiopathy, it's a biggest challenge. Now, just because I'm a spine surgeon, that doesn't mean that I should look at only spine. Just because I'm an orthopedic surgeon, that doesn't mean that I should neglect the spine. We need to have a wholesome approach to the patient. That's where we have the key factor. In fact, today with the online consultations, I see this time and again. I'm going to share a couple of X-rays later, which was taken just yesterday. It's so big. It is very rampant. The 6% what we talk about of 1.4 billion is a massive number. Half the world. It's not easy, not simple. So we need to be very careful, extra cautious, and make sure that we treat them early. Dr. Jha, thank you for the slide. And look at this. He is not able to bend at the thoracolumbar region. It is just bending like a U. In fact, it is just bending like this. He doesn't have a bend in the thoracolumbar region. And even the neck is very stiff for him. That's not easy. Now, why is it happening? We are looking at the ALL, anterior spinal ligament, and the PLL, the posterior ligament, also getting tight. Not just tight, it's just getting to fuse. So that's very important for us to pick it up early, so that we don't want to get there. Now, AP view is extremely important. Radiology is a big part of it. Now, there is a very specific reason why this X-ray has been put here. We need the pelvic X-ray. When we say pelvic X-ray, a lot of people just cut off the hip joint. Many times we cut off the ilium so that we miss the upper part of the SI joint, which is very important for us. Now, apart from this, if they don't have an access for many of those big investigations, now here, the idea of this slide is again to impress upon you, this is not acceptable. This is an oblique view, fantastic. The technician has done a fantastic, but he has not taken a complete picture of the pelvis. That's the reason I'm highlighting here. Make sure that you get a complete picture of the, sacroiliac joint, very important, and the complete pelvis. Now, we need to talk about the newer things. Yes, ultrasound is very important for us in the enthesiopathy, but when you talk about the spine, ultrasound may be having limitations there, but MRI picks up in a very big way. So that's very important. Mind you, there is a very, very important learning curve here. The radiologist who is reporting it, the orthopedic surgeon who is also an expert in the MRI reading, radiology, there are a lot of courses which is conducted. You and I can participate in that and make sure that we pick it up very early and discuss at length with a radiologist who is reporting it. Very important for all the juniors and the well-seasoned orthopedic surgeons to look into this in a very big way. So this is very, very important for us. Now, this is a very busy slide, excuse me, but inflammatory changes and the structural changes. Inflammatory, we pick it up in MRI very early. Structural, we don't want to get there because we have missed the bus in many, many cases. That's the reason we need to be very clear on that and make sure that we don't get into the ankylosis or, that is the biggest challenge. Erosions itself is, we have missed the bus. So hence, when we come into the enthesitis, synovitis, or capsulitis, we pick it up there and treat early. And if you and I are not able to treat, refer them. It's a teamwork. I know my limitations. Doesn't mean that you are inferior. No. Patient care is important for us. Hence, we need to make sure that we work as a team and make sure that the complete treatment is given and patient is going to be happy. I'm sure you and I know that. We all have learned this. This is in the history books now. But yes, we also have press of a button, we get into Google, but I'm not going to touch too much of this. Now, coming to the factor of the X-ray. Now, back pain, less than 3 months or around 3 months, and young patients. If the X-ray, the slide has been split into two because it's very crowded. I'm going to take the next slide. And then what happens there? If the X-ray is positive, then we look into the axial spondylitis is already there. Now, if that is not there, then we need to look at the staging. Is it into 1, 2, or 3, or 4 stages? It could be inflammatory, it could be pain in the buttock, enthesitis, dactylitis, like what Manish is showing on the pictures. I didn't want to sort of duplicate there, but I'm going to talk about that. PSA is a very important factor, psoriasis. Today, dermatologists are treating it, so many of us may not see that condition in a big way, thankfully, but still, it is missed. And family history is important because you and I have taken history properly, we know that. And there, you could have the staging coming in. The next slide shows there where we have a human leukocyte, antigen B27 or HLA-B27 called as, it could be positive, it could be negative. Then we talk about the MRI. In the MRI, it could be still MRI negative, but HLA-B27 positive. So we need to be very clear on that. So that's where we need to look at. And if it is HLA-B27 positive, we need to investigate further and make sure that we clear that very early so that we get the right kind of patient's treatment. Now, American Society for ankylosing spondylitis criteria is very well known. So this is, if you have 1 or 2 points, you know which staging to come in, which I showed earlier on. And similarly here, it could be HLA-B27 positive, and other 2 features can be coming in, either MRI or dactylitis or psoriatic. Or extremely important point we talked about, Manish also showed the slide IBD, inflammatory bowel disease, and the iritis, which is uveitis coming into picture, eye problem. We have to pick it up in the history, and clinical diagnosis is very important for us in examination. Now, this is where we are. Initially, we had New York criteria. Now, most of us are following the ASAS criteria and the staging it. So it could be MRI, positive or negative, HLA-B27 positive or negative, and other things coming into picture. So that's very important. Why? Because early stage in the X-ray is a very, very late stage. We can pick up the, this kind of arthritis very early on. These X-rays are showing is a very small one. I'm going to show the next X-ray in the couple of slides where we can see other things. Now, here, as per them, the diagnosis is made depending on each vertebral unit and the changes that happens here, which has been given here from 0 to 6. We don't want to get to vertebral fusion. That's where the whole challenge is for us. So pick it up early on and treat. I'm emphasizing it time and again because that's very important. Now here we see that it's already fused. We have missed the bus. Just as a spinal surgeon, you and I are thinking about only the spine. No, coming to the hip joint, coming to the it'll be fused as well. You know, a sacroiliac joint get onto the hip joints, and it's crazy. It's not easy for them. It's a very disabling and very, very annoying for a surgeon as well as lifestyle, you know, for a patient. So we don't want to get there. So let us make sure that we treat them early. And as a spine surgeon, I'm sure I don't need to talk much about it, but still, general orthopedic surgeons and the seasoned orthopedic surgeons are a part of this, presentation. Hence, dish has to be differentiated. You know, this extremely important. Why? Because here, mechanical as well as inflammatory can be done. And here, a lot of changes which we see in the anchi-spine is going to be there very earlier on. In the X-ray, we're talking about X-ray as well as the MRI. So that's very important for us. Make sure that you differentiate it very early on. Now, this is one thing I want to talk about. I said yesterday I saw a patient. This is an online. I have no chance to touch the patient. I can only see, I can examine. 5 days ago when I recommended, almost 95% of the patients whom I recommend for investigation on the online, they come back to us. And then they show the reports to us. The X-ray report yesterday, she took the X-ray yesterday, and today afternoon, morning she has reported and uploaded the entire images. I'm sure you can see that here. She also has back pain, which is there for, she's a 50-year-old lady. I didn't want to, I've concealed all the details here. And you can see that it's 16th August 2022, it's been done. And the major thing now is you can see the pain which she's complaining of. And the changes, what is there in the spine, you can see that it's not just spine. So many things are there. And in the pelvis X-ray, you know, whatever best that she could do in a tier 2 city. She comes from, not from Bangalore where I'm sitting, she comes from over 1,800 to 2,000 miles away, you know, kilometers away. That's where the whole challenge is. Patients are there. You and I are the experts. We can reach out to them and treat them and give them the right kind of treatment. Now, she also has severe pain in the knee joints. And when we ask them for the X-rays or investigations in a tier 2, tier 3 cities, people come back to us and says, yes, I will get it done. This doctor is doing something different. I want this to be, I want to be treated by this, and I want to be better. This is the kind of approach I think each one of us look into, and I'm sure we can beat this. Take-home message is very simple. I want to end this because each of us have very limited time, and we can talk about the discussion later. The take-home message is pick it up early with a systematic clinical history, clinical examination, and supported by the radiology and our blood. We can definitely pick them early. And with this, I end. Thank you, folks, for giving me the opportunity. I'm going to stop sharing now. Thank you.
Thank you so much, sir, for the elaborative talk. And so we have Professor Pal's video, but I think we should go for the next lecture. After that, we can run. Then it will be more, better. So if we can go with the next talk by Dr. J. Naresh Babu, sir. Ankylosing spondylitis, indications for surgical intervention. After that, we'll be playing Professor Pal's video, and that will be more rational. Over to you, sir. Sir, unmute yourself. And I'll request all speakers, respected speakers, to please stick to time because we have a very back-to-back lectures. So we need to, and we are receiving some questions also. So we'll discuss at the end.
Thank you, sir. At the outset, I would like to thank for detailing the pharmacological part and diagnosis part of the ankylosing spondylitis. I am here to touch upon the basic spinal problems where we require surgical approach. So it would have been nice if we have had the conservative part first, but anyway, I'll just try to complete the surgical part of it, and then we'll go back to the pharmacological management. The mainstay of treatment for ankylosing spondylitis treatment is basically a predominantly pharmacological management, but we do have 4 such situations of ankylosing spondylitis involving spine, which requires a good surgical management. And missing those things also will be a catastrophic events for the patient as well. The first one is the spinal deformity in a fixed flexed position. If the patient is completely flexed and stooping forwards and the spine is fixed, so that will pose a lot of problems in his daily day-to-day activities. We'll see as the lecture goes by. And the second problem is stability of the spine when it gets compromised. The stability can get compromised in different ways, where the patient can have a accidental fall and sustain injury, and then which can lead into a highly unstable kind of a spinal fracture. Our patients can have an Anderson lesion, which I'm going to touch upon soon. That can also pose problems in causing the instability in the spine. Third issue which requires surgical management is a neurological deficit. And many a times all these things cannot happen in isolatedly, but they can also have a combination of events where we can have the combination of either fixed deformity or fracture with neurological deficit. And these are the 4 situations which require a surgical intervention in a patient with ankylosing spondylitis. Coming to the spinal deformity, the type of surgery or indications for surgery depend on the magnitude or the angle of the deformity, how much of the patient, how much the deformity has progressed, and how difficult is the day-to-day activities. And one kind of such a severe problem, which is a peak of deformities, is a chin-on-chest deformity, where the chin gets touched onto the chin, and the patient gets completely stooped forwards. And this will lead to a kind of functional limitation where the patient is unable to look forward. And the patient is completely stooped forwards and can't extend his neck to look forwards. The gaze, the visual gaze gets obliterated, and they can't have a visual contact. It becomes very difficult for the patient to walk or look forward while driving, and sometimes even it have a problems while in a difficulty in eating as well. And this difficulty in eating happens in 2 situations: when because of there is a complete loss of lumbar lordosis and the abdomen is tucked inside, and the patient cannot have the stomach size of the stomach will be very much obliterated. I have an experience with a very typical patient where he has a functional limitation of this patient is completely stooped forwards. So the chin and face is almost touching the knees, and he has issue while he is passing urine. So the urine used to forcefully come onto his face. That is the main difficulty. He can't pass urine without soiling his face. Those are the functional limitations of this patient. This is one of the patient of ankylosing spondylitis. We can observe this patient sitting comfortably, and you can see that both hips are adducted and internally rotated, and you could not separate the hips. So you can suspect a kind of a hip pathology also involved here. But the main problem of this patient is when he tries to get up. That's what he can have. So he is completely stooped forwards. He can only see ahead when he sits. So these are the situations which forces the patients into very difficult positions where we need to correct these deformities and bring back the spine into normal sagittal alignment to have a good visual gauge. This is another patient whom you can see that completely stooped forwards. There is a loss of lumbar lordosis, and he is able to extend the neck a bit, and then he can see forwards to have visual gauge. But his neck also stuck in that particular posture. So these patients are the ones which are, unless addressed now, this becomes very difficult to manage these patients. And this is how he walks. He can't even look forwards. He's completely stooped forwards, and then he has to extend his neck and use a lot of force and muscular strain to actually look forwards to have a visual gauge, so without having an accident. And these patients have a lot of issues when they try to lie down also. See, this patient has got completely stiff spine, completely curved into like a C-shaped spine. And when he lies down, that is the position which he is to lie down. So he needs a lot of pillows to support his neck, back, the upper back and the lower back. And sometimes he needs to keep the pillows under the knees to just make him lie down. So this is not only issue for the patient, But if you are trying to correct these patients, or you are going to correct the spinal deformity and have a visual gauge, so this also poses problems not only for positioning the patient on the table, but also for intubation or getting an access, airway access. It's very difficult because we have to come forward and put the tube. So you can't put tube like that. So those situations we tend to use the neck is lifted up. This is a different patient where you will see the thoracic hyperkyphosis, and we are going to operate on this patient. So we had to put a lot of pillows to support his neck into his regular neutral position to make the spine, and we have to sometimes use the flexible uh, scopes to pass the tube uh, to get a airway access in these patients. And once you position the patient, again it becomes very difficult for you to position the patient because the spines they will be lying up without supporting any part of the chest will be lying in the air, and only forehead will be touching and knees will be touching. So we need a lot of padding and customized pillows. We need to have position the patients before itself on a couch or bed, how they are going to lie prone. Then you will have an idea of how much the support you need to keep for the bolsters or the pillows for the patient to have a. So you can't turn the patient and look for the objects to position the patient. We need to have a prior planning in these patients to get this access. So this patient we have operated actually this. So you can see this patient has a very good thoracic kyphosis, and lumbar lordosis, cervical lordosis also maintained. But his problem, why he is stooping forwards, is there is no lumbar lordosis. So there is a straight lumbar spine, and the rest of the thoracic spine is completely fused. So these patients, if you can create a kind of lumbar lordosis and then lift the patient up at the lumbar spine, and you get a lordosis in the lumbar spine, the entire spine upwards will get lifted up, and the patient can have a straighter spine, and then abdomen opens up. You can see how much of correction can be achieved by doing a simple lumbar osteotomy and correcting the spine and lifting the spine, taking the advantage of thoracic kyphosis and cervical lordosis, which is fixed, and then you can just avoid fusing the entire spine, and you can only need to fix the thoracolumbar spine and recreate the lordosis. So by this way, you can see the gaze is maintained. Patient can now look forward, and you can see the abdomen has opened up. You can see previously the abdomen is completely tucked inside. There is no space for the stomach to accommodate the food. Now you can have a straighter spine and then look upwards. This is how the patient was when he was walking before. When you operate on this patient, you are able to stretch up the spine and then can have a good upright posture, and visual gaze can be maintained very well. But there doesn't end the matter. So if you have corrected the spine, but you can see this hips are arthritic, and future I think you will come back with stiff hips, and then we need to address those things as well. It becomes difficult to decide on which has to be done first, either the hips needs to be done first or the spine needs to be done first. But this patient, where he has got some flexibility on the hips, I think spine has taken the priority, and we have corrected the spine. And during the spine also, you need to have a lot of big constructs, because you are osteotomizing not the spine. You should think like you are osteotomizing the long bone, because this bone is entirely fused and it's like a single segment of the bone. So you need a lot of anchor points, and there is a spinal cord inside which you need to protect as well to not to develop a neurological deficit. So what we use a double rod constructs across the osteotomy. We use an additional rod onto the left side so that the osteotomy can be maintained thoroughly fixed. And these patients are also osteoporotic, so we need to have a very good foundation points and fixation points. So this patient has got nicely leveled up and then corrected. These are the few indications for the deformity where you have to operate on these patients, otherwise they will end up in, they'll have issues with their daily activities of living. Other area where you need to intervene surgically is when the spine stability is compromised. These are the situations which are not so severe as the case which I showed before. These are situations where you can see like there is a crack opening of the hyperextension injury of the spine, because the spine has opened up in the front and it corrects. This is one typical situation you need to always observe when the patient with ankylosing spondylitis who has a kyphosis deformity or deformity of the spine comes back to you and says that I had a small catch on the back and now my spine looks straight. If any patient says that I have a catch in the spine, very mild pain, but my spine looks straighter now, I'm very happy. So those are the situations which are going to be potentially dangerous and cause the neurological deficit, because the patient might have got a crack opening on the front. So instead of a 3-column fracture, he might have got only the anterior column and middle column fractured and the spine has opened up. And then the posterior column is still intact. That's what is keeping the spine intact. That will also soon break and the patient will have a catastrophic neurological deficit, which is very difficult to correct. So you need to be very, very cautious when the patient with the background of a regular pain comes back with the increased back pain at particular area and there is a tenderness there. We have to investigate the patient and find out whether there is any lesion, Anderson lesion, which is existing in the spine. So this is like a small example where this patient has come up with the anti-spond with a.
Sir, sorry to interrupt you. Just we need to fasten up because we have.
How much time I crossed?
So maybe a minute, 30 seconds to 1 minute, sir.
Yeah. So there is a crack in the spine and you can see the spine has completely broken and you can see there is a dislocation of the spine which has led to neurological deficit. So these are the ones which are also called Anderson lesions and they present as a pseudo spondylodiscitis. The picture looks like spondylodiscitis. There is increased white signal in the spine and you can also see the dark signal in the T1 and there is a defect in the front. So the first look, even radiologist also gets confused and they will give report as a spondylodiscitis because you can closely observe the hypointensity goes all the way from front to back and there is a crack across the spine involving the spine as well. So those are the situations which are very dangerous and you need to intervene with these patients. We should think them as a long bone fractures, not like a spinal compression fractures which can be easily managed conservatively. This patient we have to operate with the fixation and then use the spine stability. The neurological deficit, as I told you before, when there is a compression in the spine, that can also lead to a cord compression and patient can end up with cervical myelopathy. And this can also have in combination. So this patient not only had a cord compression, but also there is a fracture, instability across the spine, and there is a broken of the osteophytes in the front, and then there is a posterior arch fracture as well. So this has to be fixed and managed with the plating. So these are the 4 situations which are very important to pick up in a regular practice when your patient you are following for a long time for a conservative management and the pharmacological treatment, and the patient comes back with these kind of situations, we should think that there is an indication for surgery as well. Thank you very much for your kind attention.
Thank you so much, sir. I think we'll go to the lecture video of Professor A.K. Pal, and then we'll go to the next lecture. So I'm starting sharing my screen.
Okay. So,
is it visible? May I start?
Yes, visible.
Good evening, everybody. Today my topic of discussion is the role of total hip replacement in spondyloarthropathy. All of you know the hip involvement occurs in 30 to 50% of the patients in spondyloarthropathy, and 90% of the patients among those with affected hips have bilateral involvement. Typically, it reflects the associated prevalence of the HLA-B27 gene. Younger the age on the onset, and the greater is the likelihood of the hip involvement. And for the risk factors, the male, axial disease, and the enthesitis are regarded as risk factors of the hip involvement. Whereas total hip replacements, it remains the most effective treatment strategy to relieve the pain and improve the ambulatory status of these patients. The aim of the THR is not only the pain relief, also the eradication of the flexion contracture, increased range of motion of the hip joint, improved mobility, and correction of the postures. There are several preoperative considerations from the anesthetic perspective, as there is restricted thoracic spinal motion restriction, so there is a less chest expansion, so pulmonary function testing is advised before surgery. A reachable spine along with limited mouth opening due to involvement of the temporomandibular joints makes the intubation difficult. Therefore, the fiber optic intubation is generally preferred, whereas the complications such as the atelectasis and the pneumonia in the postoperative period is a high possibility. Therefore, the ICU backup is mandatory. So there are orthopedic perspective, patient's age, activity levels, and the expectations should be properly counseled with the patient's relatives. There are thorough physical examination to be done regarding the spinal involvement, pelvic obliquity, everything. And the radiographs of the entire spine should be examined to rule out the presence of the pseudoarthrosis or the Anderson lesions, which can lead to some reduction of the problems. There is some reduction of the results and some symptomatic problems after the total hip replacements that should be sorted out. Now there are preoperative workup, there are preoperative standing lateral view radiograph and the lateral spinopelvic radiograph in the standing and the sitting position of the pelvis, as also the CT scan to see the pelvic malrotation is required to prevent the positioning error of the acetabular component, whereas the preoperative templating is extremely important to estimate the accurate size and position of the acetabular cup. And if the patient is on methotrexate, it should not be stopped, it should be continued, whereas the biologics, it should be stopped at least 2 treatment cycles before the operation. Now suppose, see, this is the case, this is very difficult to identify the center of the rotation. So in that case, it is a tip says good, whereas the operation. Now suppose, see, this is the case, this is very difficult to identify the center of the rotation. So in that case, it is a tip says.
So this much of video has come from Professor Pal actually. So
now I invite Dr. Ravi Gupta to talk on spondyloarthropathy, the current concepts. He is the Director of Orthopedics, Fortis Hospital, Mohali. Dr. Ravi Gupta, please.
Thank you, Dr. Aarti. And, since we are doing it for Indian Orthopedic Association, I think this is such an important topic chosen by IOA, where the general orthopedic surgeon needs to be aware of the condition. Because as I move into the lecture, we'll come to know that the main problem is when the first patient is seen by the generalists and the diagnosis gets delayed for a long time, resulting into some irreversible permanent changes, which can nowadays be avoided since we have excellent treatment. So with this background, I move on to the current concepts. Actually, many of the concepts have already been spoken by my previous speakers, but sometimes we say the repetition is important for the sake of laying the stress. So in this lecture, I will be dealing with the terminologies which are being used or which have been used and the classification, if any, what is the current load of the problem, especially in our country, and what is the recent diagnostic criteria which should be used by our general orthopedic surgeons. And I will just give an overview of the algorithm of treatment. So I would say if someone, wants to venture into treating the patients, one should be, kind of developing a special area of interest into this field, or for beginners, they can diagnose and refer the patient to the specialists. And lastly, I will also talk about the current occupational and social impacts of the problem in our society. So when we say spondyloarthropathy, it is a group of overlapping disorders of chronic inflammatory diseases of autoimmune nature, sharing certain clinical features and common genetic associations with HLA-B27. So here I would like to say it is actually a systemic disease. So initially in our MBBS days, we thought ankylosing spondylitis means only spine, but it's a group of disorders which we will talk in the next slides. The older classification was, we used to read seropositive rheumatoid arthritis and seronegative. But now, whenever the RA factor is negative, we call it as spondyloarthropathy. So we don't say it's a seronegative rheumatoid arthritis. So this spondyloarthropathy can be further a peripheral spondyloarthropathy, where the musculoskeletal areas other than the spine and sacroiliac joint are involved. And the second is axial spondyloarthropathy, where the spine as well as the sacroiliac joints are involved. So when I say spondyloarthritis or arthropathy, so that means the earlier terminology of seronegative arthritis. So seronegative when we call, so that means the rheumatoid arthritis is negative. So this is the total scenario. As I mentioned, there are two basic types, the axial and the peripheral, but there is a lot of overlapping. So one may start here like psoriatic arthritis. After a few days, he may go into, the typical, the ankylosing spondylitis. There may be undifferentiated overlapping with the reactive arthritis, which develops after, some episodes of diarrhea or this urethritis. And then there may be inflammatory bowel disease in the form of Crohn's disease or ulcerative colitis. And then there will be typical axial spondyloarthropathy, which is radiological, and also more importantly, non-radiological, where the standard criteria, which has been mentioned by one of the speakers as the modified New York criteria. So according to that, the X-ray is the mainstay of diagnosis, but we need to diagnose these patients before they have changes in the X-ray. So that was known as non-radiographic, but now the MRI is helping us. We'll talk in the next few slides. So what is the typical extra-articular manifestations? It may be anterior uveitis or just the psoriatic patches on the skin, inflammatory bowel disease, as I already mentioned, and there may be presence of enthesitis, the commonest being the heel pain, what we call as the posterior tendoachilles bursitis or tendinitis, or even plantar fasciitis. Then dactylitis in the hands is another manifestation. Now, if we talk about the problem, the load of the problem in our country, the Dr. Goswami is one person who was ex-AIMS Delhi, who has done a lot of research in spondyloarthritis. The prevalence is 0.03% to 0.2%, and this is a common disease actually, only second to rheumatoid arthritis. The prevalence has been linked to the presence of HLA-B27 in the normal population, and in India it has been studied, and it is equivalent to the West also. The 6% of our normal population, they have ankylosing this HLA-B27, but all of them, they don't develop the spondyloarthropathy. Low backache patients who are, this is one of the common OPDs for all orthopedic surgeons. Out of these, 1 to 2% patients are likely to be suffering from spondyloarthritis. So whenever you see a non-specific low backache, you must, not forget that it can be a patient of spondyloarthritis. Earlier studies, they showed that the males were predominantly much higherly involved to the rate of 18:1, but recent studies show that the ratio is 3:1. Rather, for non-radiological, it is almost the same between the males and females. The main reason is that now the awareness is more for diagnosis. So earlier patients in the females were not being diagnosed. So the incidence, the ratio was reported to be low. There is higher peripheral arthritis reported amongst the Indian axial spondyloarthritis patients. So as I mentioned earlier, when we say ankylosing spondylitis or sacroiliitis, that can involve the peripheral joints as well. Now, the average delay in diagnosis of this condition is 5 to 6 years, and the range is 5 to 11 years. So, which is, not very good. So, if you are delaying your diagnosis for so many years, some irreversible changes are bound to occur. So, what is the reason for that? Because earlier we were diagnosing only with X-ray. So, radiographic changes, they take a lot of time to develop. Presenting symptoms may not be specific, and criteria used to diagnose ankylosing spondylitis, which is, like the New York criteria, although we are changing now, I will come in the next slide, was not very, very sensitive. And lastly, but more importantly for our country, many physicians, they have inadequate knowledge, especially the orthopedic colleagues, about the spondyloarthropathy, and they underestimate the prevalence. So this slide is very important from a study from an Indian scientist, the Dr. Reddy et al. They have shown that in this pie diagram, out of 100 patients, only 31 were diagnosed. So the rest of the patients, the diagnosis was missed. And the main reason was because these were the symptoms and these were the diagnoses made by our orthopedic colleagues, like sciatica, mechanical injury, pregnancy-induced backache, spur, osteoporosis, and many others. So we must not, remove it from our mind that these diagnoses may be actually spondyloarthropathy. This side of the slide is also very important because our patients, they visit multiple type of alternative physicians, and that is one of the reasons they miss the diagnosis. This study has also highlighted a very important fact that 58% of our patients, more than half, they thought allopathic medications, they cause serious side effects. So we need to create awareness amongst our colleagues as well as in the general population that if you delay the treatment, the damage is much more than the side effects of the drugs. 25% of the patients, they believe that doctors deliberately concealed the side effects. So we need to be, having a lot of, community education on this issue as well. So I will request our president of IOA that it is our responsibility to go to the general population also. So when we think about the latest, this is the ASAAS criteria, which is being followed mostly: chronic backache, at least for 3 months or more, and age is less than 45 years. Any of these two is present, either sacroiliitis on imaging, means X-ray, plus any one of these criteria, one or more. Or the second scenario is, with this one, HLA-B27 is positive, plus any two of these criteria. So that means the sacroiliitis was not there on the right side, only HLA-B27 positive was there. But then you need two criteria from the features of spondyloarthritis. Another important fact is, it has been seen that I mentioned it takes at least 5 years delay. So why that was taking, the MRI was not there. If you get undifferentiated spondyloarthritis or axial spondyloarthritis, which doesn't show radiological features, you get the MRI, you may be able to pick up those cases at least 5 years before. Then after 5 years, the X-ray features, they start appearing. And if you still delay that more than 10 years after the onset of the disease, then you see some permanent changes in the spine as well in the form of syndesmophytes. So that means you have already done the damage. So we need to diagnose them at earlier age. Another very important recent research shows that in all the patients of spondyloarthropathies, at least 60%, they have alterations of the gut epithelial and vascular barrier, which leads to increased permeability of the gut, leading to absorption of the products of those bacteria and then autoimmunity against them. So gut dysbiosis, when we say, it is either before the onset of the disease or even after the gut inflammation has started. So what has been seen is there is some abundance of some bacteria. I will not name these 5 bacteria. And then there is some decrease in some bacteria which are normally present. So that is dysbiosis. So if we are able to find the markers for these bacteria even, then the biomarkers nowadays, the molecular biology is coming up in a very big way. We will be able to diagnose these patients even without MRI with the help of the biomarkers. But that is still a dream. Yesterday, I was in a ICMR meeting in Delhi. We had around 100 projects from India. So I think a lot of good work is being done even at molecular biology. So we need to, as orthopedic surgeons, collaborate with our biomedical engineers so that we can find out some way
to develop these biomarkers in the form of strips or otherwise. This is the current algorithm of treatment, as this is the combined. I'll finish it in just next 1 minute. This is one of the last slides. So in 2017, AS and Jular, they gave a combined recommendation of the treatment. In the first line of treatment, they say the NSAIDs plus education, exercise, physical therapy, rehab, change of lifestyle. So I think this is what Baba Ramdev is doing, and our orthopedic colleagues are lacking this. So we need to develop, we need to delve on these issues. We need to spend time on non-pharmacological treatment also, maybe through our physiotherapist, or we can guide them ourselves that, the daily yoga exercises or other exercises, some physical therapy. So they are an important ingredient of the treatment. And then, of course, they may need local steroids into the joints. And, sometimes you can use this synthetic, sulfasalazine. The second line of treatment is the biologicals, and they are mainly TNF-alpha inhibitor and IL-17 inhibitor. The others are also coming up, but, again, some people now think that the biologicals can be the first line of treatment. And lastly, there can be surgery. So my last part is the impact. We have seen that many of these patients, they get absent from their work because of the pain. Even when they are present, their efficiency is less than 50%. We call it as presentism. They are coming, but the efficiency, work productivity is not there. So more days are required with outside help, and then the days with the family and social activities is also missed. This is one of the study from abroad, where the people, they missed their work in a year for so many days. So this is also important impact on our society. This is an Indian study which shows that the 8% of the patients had to cease employment. They could not work. So this is so big a problem. So daily activities were affected up to 40% of the patients, and presentism was in 20%. So 1 in 5 patients, they could not give work productivity, and impact on work productivity is again 20%. So in summary, we must be aware with the recent current terminology in the line with the international terminology, so that our research can be communicated in a similar manner at the international level. We should create awareness amongst our journalists, especially the orthopedic colleagues, about the current concepts. We must follow the latest criteria of the early diagnosis as well as the treatment, and we should be aware of what is the impact of this disease in the society. Thank you very much.
Ravi has got a very good wisdom.
Thank you, sir, for the detailed and elaborative lecture. So may I call upon our next speaker, Dr. D. Raja, Spondylo Arthropathy and Spond Pathogenesis. And may I request all the respective speakers to be strict up to 6 minutes. And because we have many more lectures left, but we're running very short of time. So I can give a reminder on 5 minutes. So please don't feel disturbed.
Dr. Arnab,
yes,
I think we decided about 10 minutes. Let's not, make the lectures of the other speakers, because the first speakers took more time. So it's better to be a little late rather than, otherwise people will not understand in 5 minutes. If someone has made it for 10 minutes, yeah.
No problems.
So thank you, and going to talk about pathogenesis of spondyloarthritis and ankylosing spondylitis. So why we are talking about pathogenesis? Because there is limited knowledge of the pathogenesis, and there is confusion in diagnosis, as we already discussed in the previous lecture. We don't know what is the current best investigation. A lot of patients have X-ray and CT scan, and still they are not able to diagnose. And available treatment option, especially the newer disease-modifying therapeutics like TNF-alpha inhibitor and interleukin-17, we may not be able to understand unless we understand the pathogenesis, and modification of therapy before surgery is also very important. So already discussed what is spondyloarthritis. It is inflammation and pain and stiffness of the spine and pelvic joints, also associated with the enthesitis. And these group of pathologies have HLA-B27 as a common link. Other extra-articular manifestations include anterior uveitis, psoriasis, and inflammatory bowel diseases. Also have spondyloarthritis. We saw this slide before, but it's being repeated because the progression of spondyloarthritis happens over time, doesn't develop overnight. There's a period of 5 to 10 years before spondyloarthritis develop into actual ankylosing spondylitis, which is more debilitating. So we have pre-radiographic stage where there is only inflammatory back pain and peripheral arthritis and enthesitis. So patients have normal X-rays. They present with inflammatory type of pain, early morning back pain, sometimes peripheral arthritis and enthesitis. Then they progress to sacroiliitis, which is can be picked up in the early stage in the MRI and later in the X-ray as well. Then eventual syndesmoid formation and bony ankylosing happens. So there is a period of 5 to 10 years before we can actually make a diagnosis of ankylosing spondylitis, unless you know the progression of a disease and pathology behind this disease. So as we said, there is a pre-radiographic stage where we can pick up this diagnosis in the MRI, where you can see active inflammation happening in the spine and sacroiliac joint. So as we know, ankylosing spondylitis is progresses to radiological sacroiliitis over many years. It causes severe debility for the patient, and inflammatory back pain is always associated with some type of extra-articular, extra-spinal problem like enthesitis or uveitis. So presence of inflammatory back pain with one other marker like enthesitis or uveitis is diagnostic of ankylosing spondylitis. The pathogenesis, there are different theories. There is no definite pathology as such described. There is only theories. But the most relevant things are these: genetic risk factors, immune reaction, microbiological infection, and endocrine abnormality. So genetic background is really very relevant because there is a high incidence of familial aggregation, and major histocompatibility gene HLA-B27 has been linked to this type of pathologies. And there are other major histocompatibility genes other than HLA-B27 and non-MHC genes which are causing this pathology. So any patient who is genetically susceptible, you can see this familial aggregation, especially in concordant rates in identical twins as high as 63%. So in identical twins, the incidence of disease is as much as 63%. If it is a non-identical twins, it is 23%. This itself shows that there is a high rate of genetic predisposition. In first and second degree relatives, also there is higher incidence, and the incidence comes down as we go down the family tree. So HLA-B27 is important genetic marker associated with ankylosing spondylitis. It is very useful when you are assessing the first degree relative of any HLA-B27 positive patient with ankylosing spondylitis. They have 1 in 3 risk. It is autosomal codominant inheritance. 5 to 10% of the patients with HLA-B27 positive patients will develop, people will develop ankylosing spondylitis over time, and 20% develop reactive arthropathy when they come in contact with chlamydia or salmonella infection. Male members show preponderance over female in HLA-B27 positivity. People in the age group of 21 to 39 years are most vulnerable. We also see infection as a trigger in reactive arthritis. We very well know infective arthritis is usually starts after a GI infection or urinary tract infection. There is a correlation between the infectious trigger and spondyloarthritis. In ankylosing spondylitis, there is a correlation between bacteroids infection, and also 50% of the ankylosing spondylitis have some inflammation in the ileum when we see through the ileocolonoscopy. So recent literature shows a lot of correlation between the gut microbiome and these bacteria, what they have described, and they have differences between normal healthy controls. Klebsiella pneumonia is also one bacteria which is shown to have acts as an exacerbating agent of the autoimmune phenomenon. And Klebsiella pneumonia also interacts with the HLA-B27 gene, and they have relative immune deficiency as well. So the immunological and microbiological factors has been also contributed to ankylosing spondylitis. So we look at the actual pathogenesis. The HLA-B27 has a high correlation with the pathology, and there is biochemical structure, there is modification of the biochemical structure of the protein, and alternation of a conformation of the HLA heavy chain happens. This triggers an immune reaction. So we look at the actual pathology in the molecular level. There is autoreactive CD8 plus T cell receptor, which interacts with arthritic peptides. So which is attaches to the HLA-B27 and which is taken up by the antigen presenting cells, mainly the macrophages, B cells and dendritic cells. Macrophages are in the circulation. B cells are abundant in the gut. And these cells, once they take up this abnormal HLA-B27 protein, it causes unfolding of the endoplasmic reticulum. And due to this, it causes a release of interleukin-23 and other factors like interleukin-17. So this interleukin-17 causes immune response. It causes further release of inflammatory mediators and overproduction of interleukin-23. And dysbiosis of the gut also leads to production of interleukin-17 and interleukin-23. These, in effect, act on the osteocytes, fibroblasts, and macrophages, and causes release of tumor necrosis factor alpha. This acts on the end target of the body in the musculoskeletal system, which acts on the skeletal system, joints, and the gut, causing ankylosing spondylitis features like syndesmophyte formation, arthritis of the joint, and iliocolonal inflammation. So we can see the basic network, the molecular chain. Tumor necrosis factors alpha forms the important end mediator of all this inflammation, and interleukin-17 and 22 also contribute. So if the idea about this molecular pathology, we have now monoclonal antibodies which specifically target these mediators and cause suppression of symptoms and control of symptoms and delay the progression of the disease. So TNF alpha inhibitor like infliximab, interleukin-17 inhibitor like secukinumab are useful when you're treating your ankylosing spondylitis patient, not controlled with your NSAIDs. So similarly, the pathology of peripheral spondyloarthropathy, psoriatic arthritis, we have seen that they have skin lesions followed 5 to 10 years later, they develop spondyloarthritis. So they have dactylitis, spondyloarthritis, and uveitis. So again, the transition of psoriasis to psoriatic arthritis, there is a lag period. Psoriasis, after a few years, present with preclinical psoriatic arthritis, then there is a subclinical phase, prodromal phase, then actually they develop full-blown psoriatic arthritis. So knowing this stages of development help us to actually diagnose them early and treat appropriately with specific monoclonal antibodies. So I conclude by saying you need to understand the pathogenesis of spondyloarthritis to make a diagnosis, do the relevant investigation, and start disease-modifying therapeutics early if they are stopped responding to your conventional NSAIDs. And you should know when to stop these monoclonal antibodies before your elective surgery. Thank you.
So, thank you, Dr. Raza, for giving a nice lecture on pathogenesis. And so far, the program is running well, except for the time. We are running a little late as far as time is concerned. So with that, may I call upon Dr. Abhay Thans. He is from AIMS Jodhpur. He will be talking on evolution management evolution. Dr. Abhay. And I request Dr. Abhay if he can cut down a little bit of his lecture so that we can save some time. Thank you.
Okay, I will. Thank you so much. And my brief today is to talk on evolution of management and basically how the use of biologics has come around. So most of what I'm going to touch upon has already been covered. And it's great to have some repetition when you're talking of something important. So what we're going to talk of in the next 6 or 7 minutes is what is structural progression and how is it correlated to basically addressing treatment needs, radiographic techniques which are important for monitoring progression, predictors of structural progression, goals of treatment, currently available treatment options, which are NSAIDs, TNF alphas, and basically what is the role of infliximab and secukinumab. So what is structural progression? That is essentially the change of two MSAS units in 2 years at the rate of more than 1 unit per year. And that essentially decides how and what is going to be the actual structural damage in the presence of an ankylosing spondylitis or a spondyloarthropathy. So radiographic techniques which are important for monitoring structural progression, essentially, these are the conventional radiographs, the CTs, the spectral CTs, ultrasounds, MRIs, and the different modalities of MRIs which are available today. And on basically 2 counts, all these investigations are utilized. One is to see the inflammatory nature of the changes, and the other is to see the structural damage because of the inflammatory parameters. And if you see, the CT scan is a very, very useful tool, as it is extremely important and shows us what is the kind of structural change or chronic damage that has happened over the skeleton. And the other thing is the MRI, various different scans which have utility in identifying the MRI needs. For example, sacroiliitis and basically perisacroiliac osteitis can be beautifully demonstrated with the use of an MRI scan. So what are the predictors for structural progression? Essentially, these are the habit, the disease activity, inflammatory markers, and the radiological markers. And the 2 predictors for structural progression are the disease activity predictors, which are the ankylosing spondylitis disease activity score, that is the ASDAS, and the Bath ankylosing spondylitis disease activity. And both these parameters have a very significant p-value change, and it correlates extremely well with the structural progression of the spondyloarthropathy. Now, essentially, the predictors are which habit predictors are present in different individuals, and it has been observed that smoking is one of the most important predictors for progression of disease, and smokers often suffer a dose-dependent deterioration in the structural damage over a period of 2 years. The other inflammatory markers, ESR and CRP, both have been correlated with progression of disease, but they are slightly non-specific in the sense that the predictors are present in about 70 to 80% of axial spondyloarthropathies. So what are the goals of treatment? Essentially, the goals are to maintain quality of life, to control symptoms and inflammation, and to prevent structural damage. And what is the current scenario and the dilemma? The current scenario, essentially, according to the EULAR criteria, is what should be the end target of therapy and what should be the optimum time of initiation of therapy. So the current available treatment options, as has already been discussed, is the NSAIDs, the TNF-alpha inhibitors, and the IL-17A inhibitors. The current available options very clearly enunciate that the NSAIDs are the first point focus of treatment. These provide pain relief and suppression of inflammation, and the treatment goals in axial spondyloarthropathies focus on potential deceleration and the arrest of damage. If one has to emphasize and find out what is the actual effect of NSAIDs, it is essentially symptom control and functional improvement. Whether non-steroidal anti-inflammatory drugs help in stopping or slowing radiographic progression, there is some evidence to say for and a lot of evidence to say against. So one really does not know if NSAIDs do stop progression of disease, but they definitely help in symptom control and functional improvement. The next drugs which are useful are the TNF-alpha inhibitors, and it is a very important mediator of inflammatory, mediator of disease, and that forms the basis of a lot of biologics that are in the market. And what is important to understand is that it is increasingly being emphasized that TNF-alpha inhibitors are important not only for end-stage disease, but also for early-stage management of disease to prevent disease progression. And it has been also emphasized, as has already been discussed by previous speakers, and Dr. Ravi Gupta said, that early use of the TNF-alpha inhibitors has been recommended for patients who are diagnosed with ankylosing spondylitis according to the NBI criteria and treated with more than 2 non-steroidal anti-inflammatory drugs drugs over 3 months, whether early or later in the stage of disease management. So certain types of treatments have been indicated to progress over, and a lot of studies have been done on this, and especially to highlight which spinal lesions are associated with newborn formation, especially with angsponds treated with TNF-alpha agents. So the type of lesions that progress are essentially those where signs of inflammation are present without any other pathologic finding in parallel, and those in which the signs of inflammation have a concomitant fat signal. Fat signals without signs of inflammation, and some where have no lesions at all. What is the effect of TNF-alpha therapy on newborn formation? Current evidence demonstrates a mixed role, but continuous long-term anti-TNF therapy has shown does not lead to an increase in the rate of newborn formation over 8 years in patients with ankylosing spondylitis. And the picture that has evolved over a period of time says that over 2 years of TNF-alpha inhibitor has had no effect on structural progression. So clearly the picture is very mixed, and one really does not know which way to profess one way or the other. So the picture is mixed, and the evidence is both for and against this particular theory. So what are the theories as to why fusion proceeds despite there being an inflammation control? Probably because the joint fusion is triggered by the initial inflammatory insult rather than the later progression of disease. It is possible that the low levels of inflammation persist irrespective of inflammation control, which drive joint ankylosis. And fusion essentially is a consequence of inflammation itself. Whether it is related to a TNF-alpha therapy, that remains controversial and still to be understood. So infliximab and secukinumab are two drugs which help, and a very brief touch upon what they do. So over 8 years of infliximab has demonstrated that there is no effect on structural progression and inhibition as compared to patients who do not receive biologics. And secukinumab has a fully human anti-interleukin 17A monoclonal antibody has demonstrated sustained improvements in the signs and symptoms of ankylosing spondylitis through 2 years. So much for now, and I would leave the rest to be covered by subsequent speakers. Thank you for your time.
Thank you. Thank you, Dr. Abhay, for a short and sweet lecture. Now, with great honor, I invite a legendary figure from Calcutta, Professor Biplav Acharya, sir. He will be talking on his experiences on spondyloarthropathy. Sir needs no introduction, but it's really a great pleasure and privilege, sir, that you are here. After a long time, we are seeing you on the screen, and sir is our teacher. We have learned so many things, sir, from you. So again, it's a privilege for us to learn from you. So, Professor Biplav Acharya.
Thank you. Thank you all. And thank you the organizer of IOA, Indian Orthopaedic Association, and the scientific section of the IOA in Indian Orthopaedic Association. First of all, I want to say that the spinal arthropathy, and the SPA is the same thing, but the cause is different. It's difficult to diagnose which is responsible for these particular problems. For that, we require some investigations according to the need. And everybody knows that it is an autoimmune disease. And autoimmune disease it has a multiple organ disorder. So Patients usually come with a low back pain and fatigueness like that. And then we want to localize who is the cause. What is the cause of this pain? It is known that the orthopedic surgeon should examine the patient thoroughly. It is essential. And after that, they will conclude the cause of this low back pain and others. Without proper examination, it is very difficult. Only by investigation, it cannot be done. And in advanced stages, now the MRI comes up. Before that, there is a radiology, X-ray, and everybody knows that in NIS Medical, when I was house surgeon, and there was a center of rheumatology clinic, and Professor Dev was, and Professor Orthopaedics, and Professor Monjumitri was in medicine, come up. After their retirement, the clinic is about to be closed. This is the job of the Indian Orthopedic Association to bring up how to make the clinic survive. And everybody knows that the arthropathy, the most cases, the drugs, anti-rheumatoid drug, the criteria of the rheumatoid arthritis affecting the spine, and everybody knows the drugs, the NSAID, steroid drug, and DMRD, disease modifying rheumatoid arthritis drugs, and surgery requires less. Ankylosing spondylitis is the common problem of the spinal arthropathy. In our country, the ankylosing spondylitis is less, as already told by other speakers. And in our country, rheumatoid arthritis is less. For that, we use the anti-rheumatoid drug, and somebody mentioned that the that is the tumor necrosing factor. It has a good effect, but monitoring is very essential. It is not possible in the subdivision and district hospital in India, even in the teaching institution. So it has a bad side effect. So we usually use the disease modifying drugs or rheumatoid arthritis, against rheumatoid arthritis. Everybody knows. So in spinal surgery, it requires the excision of the synovial membrane and fusion of the joints, the facet joints. In cervical spine, usually in the already mentioned in the ankylosing spondylitis corrective osteotomy, but it is not so easy. It is very difficult to spinal corrective osteotomy, because the correction is necessary all around the spinal cord. So this is my observation in a small period, though I didn't get good environment for the work, that is the rheumatoid arthritis. It is essential now. In our state, Dr. Partho has taken the responsibility for developing this, and he requires sometimes he usually do the spinal surgery. Thank you all. Thank you the IOA and thank you the scientific subcommittee. Thank you.
Thank you, sir. Thank you very much for the the gist you have presented over here. Really, it's highly appreciable, and we will take care of your words. Now, we move on to the next speaker, Professor A. Rajamani from Madurai. He will be talking on cytokine inhibitors and spinal surgical intervention. Dr. Rajamani.
Good evening to all. First of all, thank you for making my presence here at this odd time. I am taking in the finisher role for want of time. Is it working? Yes. And my talk from the previous speakers has made my job easy so that I can straight away go into the topic, and everybody, all of us know that medical or surgical treatment do not cure the disease. So the aim is to reduce the pain and halt the damage. So the goal is to control symptoms and to prevent further damage and correct deformities. Medical treatment, as you all know, the DMRDs, and the next what is currently is uses other drugs which fight against certain immune cells, either reduce immune mediators or block immune cell functions. And the medical treatment of all these things, they do not work. When the first line of drug DMRD do not work, we are going for a second line of drug, that is biologics. And always try to choose a less potent drug first, because if medically suppressing the immune system too drastically can cause to stop other fighting infections, bowel infections or other infections. In that way, treatment has to be individualized, and the response vary from one to another individual because of the gut microbiomes, which has been already discussed elaborately by the previous speakers. Because there are certain bacteria which convert the fibers into a short chain regulatory cells to suppress the inflammation. At the same time, there are other bacteria hinder high drug absorption, drug state, which delay the absorption. So that treatment varies from individual to individual. So basically, to start with, cyto means cells, the kinos means movements. It is basically a low molecular weight proteins, a glycoproteins, which has got a significant role in induction and regulation of cell immune system. It is an important role in inflammatory response and as well as hematopoiesis. It is basically involved in the cell-to-cell communication in a coordinated immune response. It has got a very good role in both innate and adaptive immune response. The modality of actions of cytotoxic inhibitors are either the synthesis of cytokines is production is minimized, or the available active form is reduced, or there is a receptor block, or there is a signaling of the cytosine receptor is intervened in the genetic modulation inside the cell. Now, we take a few drugs of the reduction in cytokine synthesis. As for all you know, azathioprine and methotrexate as immunosuppressants as well as anti-inflammatory agents. The mycophenolate is the one which is a monoclonal antibody, mainly suppress the lymphocyte population by the complement lysis. Then there are others group drug which is a glucocorticoid, which we know before we come into act as put into it the cytokine inhibitors, anti-inflammatory, which as well keep the cells viable, but it reduces the cytokine formation by inhibiting the interleukin-1 and tumor necrosis factor. In this way, the glucocorticoids act as a cytokine inhibitor also. Now coming to the other group of drugs, which is reducing the cytokine active forms, which is a monoclonal antibody, infliximab, which already been very well discussed, which act with the antigen binding parts of the tumor necrosis factor, which acts with the basis of the IgG molecule. And currently, the another soluble receptors are used, which is also a monoclonal antibody, but it acts with the gene technology to non-antigen binding parts of the IgG molecule receptor of the T-glucosis factor. Now there are certain drugs, doxycycline and dexazolimab, which acts on the target, inhibiting the cytosine receptors, thereby antibodies against interleukin T and then the blocking receptors for the central T lymphocytes, which suppress the cellular immune reactions. Then the last one, which is currently on the go, is being tried in the AIDS, that is sirolimus, it's a rapamycin, which intracellularly acts, the genetic signaling is stopped, receptor blockage inside the cell. So in all these four ways, the cytotoxin inhibitors are used, which of course, as an operating surgeon, I do not have much experience of this. I have just exhibited my knowledge and what a surgeon has to know about these drugs. Queries can be asked with my rheumatology colleagues. So now we come to the second part of my talk, that is surgical spinal intervention. It's already covered by my previous speaker, Naresh. Basically, there are serious situations which surgery is indicated in the spine. One is instability, which is causing pain. Another one is producing deformity. Another one is a neurological deficit. These things can be very well treated by osteotomies, decompression, and instrumentation and infusion. But these patients, they have a caution about before doing surgery. That is because most of the patients have a long-term steroids, which produce an osteoporosis, which gives a problem of stabilization and achieving fusion. And the prolonged steroids will do a delayed healing, both for a fusion and wound infection following surgeries. And other joint involvements, hip and knee, have a delay in rehabilitation process, and one should have a caution about this. Before surgical intervention, we have to restore the cardiorespiratory surgery. Think about it, because mainly this is a problem of surgery per se by the anesthetist, but following immediate post-operative period because of the deformities. Positioning, already mentioned earlier, it's very difficult in certain cases with the gross kyphosis with the neck and chest involved. It's very difficult to position the patient, and as well it gives a problem for intubation to the anesthetist, which have been very well described earlier. And once again, why to stop these all biologics before surgery? In preparation of surgery, this also includes 2 to 3 weeks prior to surgery, you have to stop that, and then we have to restart it. So in these situations, following surgery, you anticipate wound infection and treat accordingly. And above all, in spite of a bone formation is there in ankylosing spondylitis, we may have a problem of osteoporosis and stabilization of fractures. And this is a real situation where it is a gross kyphosis, cardiorespiratory reserve is there, patient is not able to see straight because of the head is totally chin to the chest deformity, and totally the posture is to be corrected by way of varieties of osteotomy we have got. But basically we do a pedicle subtraction osteotomy and split-Peterson osteotomy. You have to be very careful in doing all these types of osteotomies, have a neuro monitoring center which is possible. And nowadays we have got a lot of gadgets like navigation and all, so that we are able to safely do the corrections of this surgery very easily. Next is a deformity in the sagittal balance, a flat back and a pain in the back. That we correct by all these intervening disc spaces, and then the pelvis on all these equipments are available nowadays to correct the flat back like this. And then not only this, hip and knee involvement, which as I told you earlier, which has to be treated simultaneously depending upon the priority of the problem. You have to give weightage whether you have to correct the spine and hip, but both has to be attended with way of joint replacement. And it's a progressive disease. One surgery is not enough, because it's a progressive disease. Over a period of time, you may have to do a repeated surgery, second again in another region, maybe in cervical or maybe the joints, something like that. So we have to very well inform the patient before venturing surgery on this. And this is a situation, another situation where a trivial injury can go in for a fracture, which because the whole spinal column, both proximal and distal to the fracture, moves entirely in a single column, and the neurological deficit comes in easily in these situations. And the stabilization procedure is a must in these situations to avoid neurological problems and then the patient is pain-free. And then one more thing I like to, for completion's sake, in the upper cervical spine, commonly the cord compression happens by the inflammatory tissue or as well the damage of the C1, so that around the oxide dislocation happens in the upper cervical spine, which is a life-threatening issue. And in those days, we like to do a simple procedure of groups C1, C2. And if the situation warrants, if the more damage is there, probably we have done some cases of occipital-cervical fusion compromising the appendoxy joint movement, and then the patient can never say yes or no in their lifetime. But nowadays, the more and more gadgets are available. We save the occipital-cervical movements, and then we see the lateral mass of the pedicle screws. We have got it, and then so we save the occipital-cervical movements and achieve a stabilization with the decompression, so the neurological part of it is taken care of. And so to conclude, because I want to finish in time, I want to be point. It is not no cure for the disease, basically. And the aim is to reduce pain and halt joint product breakdown, control of symptoms and prevent further damages. We have to realize it is a lifelong issue with waxing and waning, and we have to make the patient functionally comfortable. And the treatment has to be individualized with the basic of NIH, DMARD, and Biologics inhibitors. Coming to the surgical intervention part of it, cannot cure the disease. Pain and deformity in neurology has to be addressed surgically, and technical difficulties, intubation, positioning, preparing the patient prior to surgery, when to stop the drugs, when to restart the drugs after the surgery, all these things has to be taken into care of, because you have to take care of patients and then the long run avoiding infections of the surgical wound. And the results vary depending upon the individual profile, disease status, and other joint involvement for hip and knee for the purpose of rehabilitation. And surgery has got a definitive role in the previous indications by way of osteotomies, decompression, and stabilization. And repeated surgery is necessary in all these patients because it is a progressive disease spanning for the lifetime. Thank you so much once again for giving me the opportunity to share my experience with you and all. Thank you.
Thank you, sir. Thank you for a great lecture. So now the next speaker was Professor Santanu Lekar from Dibrugarh. But just few minutes ago, I got a message from Dr. Lekar that he is stuck somewhere and could not join today. So we missed his lecture, but sir has assured that in future he will be very much with us. So anyway, then we move on to the next lecture. So with great honor, again, I invite another legendary figure of this evening, Professor S.S. Jha from Patna. Sir is not only a great teacher, but mentor and guide for us as far as orthorheumatology is concerned. So sir will be talking on biologics in special situations. Professor Jha, sir.
Professor Rajamani, stop sharing. Stop sharing the screen. Right. Now I share the screen, and in the meantime, I am not talking on biologics in special situations. I will be talking about guidelines that has been framed for IORA and IOA. So let's talk about guidelines. This is nothing but a final briefing on the management protocol starting from the very beginning. Friends, Spondyloarthritis Guideline 1. I have made 11 guidelines for our association. So from history, you have to suspect that it may be a case of Spondyloarthropathy in a patient who is coming 3 or more months complaining of chronic back pain, and age of onset is less than 45 years. You have to requisition MRI of the sacroiliac joint and HLA B27. Number 2, ascertain and classify whether it is axial spondyloarthritis or peripheral spondyloarthritis. Number 3, you have to determine whether the disease is active or stable. Active is an axial disease and symptoms are at an acceptably bothersome level. Inflammatory status has to be judged as per clinician's examination. Stable ankylosing will be either asymptomatic disease or the symptoms are there at an acceptable level and clinically it becomes stable only after minimum 6 months of treatment is required. Number 4, first line therapy is, remember everybody has said, NSAID, continuous 2 NSAID for 4 weeks. It could be first for 1 and then second for 3, or first for 2 and second for 2 weeks. There are no preferred NSAID. It could be one of your choice. No systemic glucocorticoid is recommended to be administered. Peripheral arthritis, you can use sulfasalazine over methotrexate. Now the first line therapy, if there is confinement to the two peripheral joints or less than 2, you can here go for local glucocorticoid infiltration like in sacroiliac joint, but avoid enthesitis areas like Achilles, patellar and quadriceps areas. Physiotherapy is a must as has already been overemphasized. Number 5, active ankylosing spondylitis still despite NSAID. So now comes the role of second line therapy, and in second line the first choice is TNF alpha inhibitors. No preference. Second choice is secukinumab or exezumab, and third choice is the latest tofacitinib, the small molecule. But for a patient of ankylosing spondylitis with inflammatory bowel disease or uveitis, you prefer the monoclonal antibodies infliximab, adalimumab, certolizumab, golimumab over other biologics. Number 6, I say stop, look and go. Maybe by now your patient has not got the proper relief. So wait, further investigate, and here is again a time where you can repeat spinal or pelvis MRI. Guideline number 7, active disease and is not responding. So now comes the role of third line therapy. First degree non-responder despite TNF alpha inhibitor. So first strong choice will be secukinumab or exezumab. Second choice could be tofacitinib. Second degree non-responder despite TNF alpha, you can change to alternative TNF alpha. Friends, we must be against non-TNF alpha and non-secukinumab, exezumab therapy, and also should not add sulfasalazine or methotrexate for this region. Number 8, now come to the stable cases. Physical therapy, yes. Stable ankylosing on biologic, do not discontinue the drug, but taper the biologic. NSAID on demand. Stable on TNF alpha inhibitor and NSAID, now you can stop NSAID. Stable ankylosing spondylitis on TNF alpha, oral targeted synthetic DMARD, that is tofacitinib. Continue TNF alpha inhibitor alone and stop targeted synthetic DMARD. We must take a note that originator TNF alpha inhibitor Do not switch over to a biosimilar from other company. Guideline number 1, you have to monitor the patient as has already been enumerated by -CRP or -ESR scores. Avoid using treat to target strategy and avoid repeated spine radiographs at scheduled intervals. Avoid obtaining spinal or pelvis MRI to confirm inactivity. Guideline number 10, arthritis might require a joint replacement. Severe kyphosis, in expert hands, go for spinal osteotomy. Otherwise, if there are no spinal centers, avoid. Osteoporosis, spinal fusion could be recommended, but do not ever go for spinal manipulation. And guideline number 1 for our country, we recommend using traditional DMARDs from the very beginning in higher doses or following biological therapy whenever cost becomes a constraint. Like for example, sulfasalazine, even otherwise, has potent anti-inflammatory effect similar to biologics, also antibacterial and immunomodulator properties. If it is a case of psoriatic arthritis, higher doses of methotrexate are more effective and results are comparable to rheumatoid arthritis. Remission could be achieved in 20% of psoriatic arthritis. So friends, with these 11 recommendations, you can limit your diagnosis and management. Thank you. Thank you very much.
Thank you. Thank you, sir. Thank you very much for giving a clear picture about managing the spondyloarthropathy. Now we have, am I audible?
Yes, yes, you are very much audible. Thank you.
Okay. So now we have come to almost an end of the program, and I would like to call upon a man who was behind the entire program, a dynamic person, the convener of the IOA Spine Subcommittee of IOA, Professor Parthasarthi Sarkar, to for giving a conclusive remark. But I think before he put on conclusive remark, shall we take 1 or 2 questions, sir? Because I can see 1 question in the chat box.
Sure, go ahead.
So 1 question for Dr. Ravi Gupta. Dr. Soham Ghosh is asking that how often do you prescribe MRI in orthopedic OPD in cases of non-specific back pain?
See, firstly, clinically, we need to ascertain whether it is inflammatory backache or it is mechanical backache. And then you should have at least backache continuously for the last 3 months. So in those cases, I will be having very low threshold to get the MRI.
Right. And what again becomes important, that you have rightly said, that duration of symptoms. Suppose a very frank, you can open the back and look at it and come to a conclusion that this is nothing but not only spondyloarthritis has come into the stage of ankylosing spondylitis. So first get an MRI, and as Dr. Amarnath was saying, sacroiliac joints are to be seen, and for better visibility of sacroiliac joints, it is the posterior anterior view of the pelvis in which the sacroiliac joint becomes very visible. It could be oblique view as well. But as far as the recommendations are concerned, if it is a very short duration, you have to ask for this MRI, because it will be in this pre-radiological stage that you will not miss the diagnosis. The marrow edema, the erosions can only be seen in MRI, and that is why MRI should be recommended if you have suspected it. And not only MRI, HLA-B27 also is a costlier investigation. This also must be asked for.
Okay. And
I think the more important thing
Yes,
is
yes.
we must ascertain that the symptoms are present consistently of the inflammatory backache for at least 3 months. That is the recommendation. So what happens is, in our day-to-day OPDs, we see a lot of patients of low backache who are, kind of stressful working and atmospheres. If you look at the causes of backache, the 60% causes of backache can be related to psychogenic. So in those cases, the backache will be not so consistent and inflammatory. That may be a kind of, intermittent, and then the consistently after rest, the pain will not be there. And, that is important. Then you go for MRI.
And always look for associated features like enthesitis and other involvement. The history itself, that the patient is worse in the morning and improves with activity.
Okay. So I can see 3-4 more questions, but I think because of the time constraint, we will take one more. The second question, someone is asking that how to decide the use of biologics, particularly between the TNF alpha blocker and interleukin 17 inhibitors.
Yes, you have to also look into the economic background of the patient. That also becomes very important. And as I have graded various guidelines, this is not a first-line therapy, this is not second-line therapy, and also this is second and third-line therapy both. So you should not quickly jump to secukinumab. You can start with infliximab. And in my own experience, I have found that etanercept is equally good. And presently what I find that the FDA has recommended use of tofacitinib in seronegative spondyloarthropathy. So infliximab, even the other etanercept can be used, and you can keep secukinumab as reserve.
Okay.
Only advantage with secukinumab is that the progression of the disease is said to be halted, but then it has to be used for maybe very many years. 4 years studies are there.
Okay. So thank you, sir. And now at the
Sanjay,
end.
Sanjay,
Yes,
just sorry
yes,
to interrupt.
Okay, okay,
Dr.
sir.
Jha was mentioning about it. Just want to add on a couple of things on the financials.
Okay.
Now, Dr. Jha, thank you for bringing in the financials, because today, after being in the insurance segment for almost 12 years, now I can tell you this treatment can be given in certain medical policies up to 8 months in a year. Up to 8 months in a year. Some companies give you 6 months, but if you have any challenges, if any of you have challenges, just message me. I will guide you through how to go about it. Thank you. Thank you.
Right. That will be a good step.
Thank you, sir.
Can I just add a small thing for our general orthopedic surgeons? I will say that don't just venture to give biologicals as the medical representative is coming to us and telling us that this is the drug, which you can give. It requires a lot of experience. It is a double-edged weapon which can have systemic implications. So I would say, if you want to start, be in touch with an expert and then try to follow the advice, or maybe you can work as a member of a team with the rheumatologist, and then you slowly go into that path. So that's my advice to all youngsters.
I always keep on saying, become a master of the basic NSAID, the conventional synthetic. Unfortunately, sulfasalazine still has some role, but others do not. But do not forget leflunomide. That also is expected to give good results.
Okay, thank you, sir. So I think Dr. Aarti and Dr. Arnab, can you say any other question in chat box?
I don't think so, but I think so. All the areas have been cleared regarding the financial constraints and regarding the treatments. Dr. Jha has told to us about, and Dr. Ravi the current concepts. So I think so. We need much more lectures to clear this because this is a very vast subject and the new upcoming subject. And I think now we can conclude. And I'll now request, I think so, Dr. Parth. Dr. Parth, are you?
Yes. Thank you. Thank you.
Okay.
Yes, sir.
No, I thought Dr. Raja has to say something.
Okay.
Raja?
Yes, sir. We already discussed the basic pathogenesis. So any young patient with inflammatory back pain with enthesitis always suspect spondyloarthritis, and MRI is a good tool. And once you understand the pathology, we can go for further biologics, which are very helpful these days in treating and controlling the symptoms. So one need to be aware of the pathology, and as we already discussed, you should know when, which drug to use and when. So it will be helpful for our patients.
Okay.
Okay, thank you so much. I am very much grateful to our parent organization, Indian Orthopedic Association, for giving me the opportunity. And I also thank our senior teacher, our mentor, Professor S.S. Jha sir, for helping me to make this conclusive note. The seronegative spondyloarthropathy or axial spondyloarthritis has sacroiliitis and enthesitis as a hallmark of the disease. MRI of the pelvis is preferred imaging modality for identifying the osteitis of sacroiliac joints. And HLA B27 is another milestone investigation. Axial spondyloarthropathy is a chronic systemic inflammatory disease affecting the sacroiliac joints, spine, and occasionally peripheral joints. The sacroiliitis evident on plain radiograph is characteristics of ankylosing spondylitis, but it is more advanced presentation of the disease. However, it typically takes 5 to 10 years from the onset of the inflammatory back pain until the development of the definite radiographic sacroiliitis. But there are patients now called non-radiographic axial spondyloarthropathy, in which it does not progress over time to definite radiographic changes. The assessment of spondyloarthritis, International Society ASS classification criteria have been developed for patients with back pain greater than 3 months and age of onset less than 45 years in order to identify the early disease. A clinician has to be aware of early clinical presentation of enthesitis and should proceed to further investigate so that early diagnosis is not missed and treatment is instituted. Unlike rheumatoid arthritis, axial spondyloarthropathy does not respond to all conventional synthetic TMRDs. While TNF alpha and interleukin 17 are very effective in both spinal and peripheral joints, we have to train ourselves in instituting such therapeutic measures by regularly involving this kind of scientific activities by IOA and Indian Orthopaedic Rheumatology Association. And I must thank our course in charge, Professor Sanjay Keskar, and wonderful moderator by Dr. Arnab Karmakar and Dr. Aarti Diwan. And I must thank Professor S.S. Jha sir for the whole concept and Professor Manish Khanna sir for the wholehearted support, and also our esteemed faculties, Professor A.K. Pal, Dr. S.S. Amarnath, and our chairman, Dr. Naresh Babu, Dr. Ravi Gupta, Dr. D. Raja, and Dr. Abhay Essence, and my teacher, Professor Biplab Acharya, Professor A.S. Rajamani, and above all, our president, Ramesh Sen sir, for his encouraging word. And with that, I want to share my experience of our chairman, Dr. Naresh Babu. Sir, please conclude the session.
It's an excellent program, Partha. No need to, nothing to add. It's a wonderful program. Had many more things to pick up and learn. In spite of, though we deal with so many spondyloarthropathies, the knowledge what we have gained is definitely going to help us in daily routine. Thank you very much for all the student faculty and Indian Rheumatological Association for taking the initiative and being a part of our spine program. Thank you all.
So, sir, before ending, I think there is a proposal from Professor A.K. Pal that in near future we have to, again, you give us a chance so that we can hold an academic program related to surgical aspect, because this time we have not covered much because of scarcity of time. 2 lectures were there as far as surgery is concerned, but could not cover it in this thing. So I request the IOA Spine Subcommittee to give us a chance, another chance. After 3 to 4 weeks, please give us a chance to hold another session, particularly on surgical aspect.
It's all our pleasure. I think Pardo has already planned for 5 more. So that's what he has been
okay. Okay.
We'll be in touch with you, and then we can have a
Okay, sir. Okay, sir. We will continue. We will continue, sir.
Okay.
Thank you so much, sir. Thank you so much, sir, for your whole support. Thank you all.
So thank you all, and I
think that Dr. Professor Jha sir and Manish Khanna sir, if they have any experience, or sir, please share your experience regarding this. Then it will be complete. I think so.
I think you have planned it so well. You deserve all praise, the whole team. And I'm happy that we have been able to coordinate with the IOA Spine Subcommittee. I myself belong to the Rheumatology Subcommittee of IOA. So a great coordination, and thank you everybody. And I was happy to see Professor Biplab and was very happy to hear his words. Dr. Pal, he has come back. Yes. Have you come back, Dr. Pal?
Yes, sir. Actually, I was there. Actually, I was traveling, and I'm requesting all to make another program on surgical treatments.
Right. Under the constraints, it has been well planned. And I must express that all the master trainers who were here had very, very smart presentation. Thank you, all the master trainers also. And Dr. Dilip has left. Professor Dilip.
Oh, sir, sorry, sir. Dilip sir is a mentor. Really, he was so much active in this total program. He has not been able to have any lecture, but he is so involved that before the program started. Sir, please share your experience, sir. Dilip sir. Sorry, sir.
I think he's not.
Dilip has left. Dilip has left.
No,
Sir.
Oh, sorry. Okay, sir. Okay, sir.
Okay, right. Okay, so you can end it on a happy note that all was really well.
Sir, fortunately, we have Dr. Aarti. She is the only lady orthopedic surgeon who is interested in spine, because most of our lady orthopedic surgeons, they are interested in pediatric orthopedics. So we are very fortunate, and really we are happy that Dr. Aarti is with us.
She has been calling from the very big morning.
Right. Okay. So let's conclude the session, sir, and
you can do.
So good night to everyone.
Good night. Good night,
and
I think Manish also is not there. Manish, are you there? No, no.
So it's already 25 past 10, but still we
Yes,
have
yes.
more than 20 participants. Once upon a time, it was touching 40 participants. So,
okay.
So thank you all for.
Most important is that it is recorded, so anybody can look into it anytime one likes.
So Dr. Dilip has come back.
Okay, Dr. Dilip. Dr. Dilip.
Unmute karo bhaiya.
Sir, Dilip Nunda, sir, please share your experience, sir, regarding this webinar.
Yeah, this is a very good seminar comprising of almost all the spheres of the spondyloarthropathy, and the way of 11 points that you told are really is a landmark, you know. The 11 points to take, the IOA guidelines and the rheumatology guidelines that you told, Professor Jha, I'm talking to you.
Right.
Yeah, it is actually has got a great meaning, and it is actually helpful for all our treating doctors. This is number one. Number two, this Ravi from Chandigarh, I think. He is in Chandigarh,
Yes,
no, Ravi?
yes.
Government Medical College, Chandigarh.
No. He has shifted to Fortis. Fortis.
Huh? He has shifted to Fortis, sir. Earlier he was in Government Hospital, Chandigarh.
Oh, I see.
Now he has resigned and he has shifted to Fortis Hospital, Mohali.
Fortis Hospital, that is in Chandigarh.
Yeah, Mohali, Chandigarh, yeah.
Right.
Yeah, so he has told, he has actually got a very concise and beautiful wisdom of presentation that I observed. Only it can be possible from a mature person that he has told us about that thing. So that I am happy with that. Third thing is regarding this arthroplasty in your spondyloarthropathy. Yes, it is actually it is the last resort, actually, replacement of the joint. That is there. Amarnath has got a very good proposition, and he has given us our a boost for our this financial help, so that the insurance company can help us for 8 months. Then actually it is either it is 8 months or 6 months. I think it is 6 months, isn't it?
Yeah, I think we'll definitely discuss further. But yes, there are certain companies which give you 8 months. There are certain companies which give you 3. You will get a chance to from 3 to 8 months, I would say, depending on the company.
We will take help from you. Don't worry. And lastly, as our Keskar, I must thank Keskar because he has coordinated well, and he has also asked that because of the limitations of time, he has actually only took up 1 or 2 questions or 3 questions like that. So cleverly he has managed everything. And the organizer, among all the organizers, I must thank everybody, including that convener and our this Partho. Partho has done a wonderful job in finding out people who are sleeping for long years. People who are sleeping for long years, and he has awakened them and activated them to come to and open their mouth in the forum. So thank you very much, and I appreciate the endeavor. And everybody knows this IOA. People, they know very well that what this subspecialty is doing for several years. So Amarnath, thank you very much. We will see you. Yeah. Namaste. Jha Sahab, namaste.
Bye.
Yeah, bye. Thank you.
So let Keskar wind it up. Keskar?
Yeah, Keskar is there till the end.
Amarnath, you have a dual role. You are visible twice.
No, I must. Biplav Acharya is there. I told that people were hibernating for a long time, and now actually it is Partho who has brought them into the oblivion. Thank you very much. Thank you.
Right.
And Naresh Babu has got a very good background that I observed today. The background of your setup is very nice.
Very good presentation he
meaningful.
had. Yes.
Thank you, sir. Thank you very much.
Thank you. Thank you. And yeah.
Keskar,
We have to end with the smile of our Keskar. You know.
Keskar, close it now.
Somebody has
Yes,
to.
sir.
Is,
yes, sir. Yes, sir. So, so as you said, we are closing it, sir. So
Right.
thank you all. Okay.
Right.
Thank you, sir. Thank you.
Bye.
Good night, sir. Good night, everyone.
Good night. Good night.
Okay,
Good night.
sir.
Good night. Good night. All.
Thank you, Partha. Thank you. Thank you, Keskar. And now Keskar is busy for this MCI, isn't it?